All right, you guys, we're gonna get started. Welcome to noon conference for Friday. We have another basics conference. I think this one's gonna be really fun for us to go through. So today we're gonna differentiate between inflammatory bowel diseases. We're gonna manage an inpatient IBD flare, and then identify connection between IBD and liver disease. I try to make these lectures, as I always say, to fill an illness script in your mind. As well, for our third-year residents, there are some pearls that appear on boards as well. So trying to capture the breadth of the audience. So for those of you that have been able to join on poll EV, and for all of you here, which side do you think looks abnormal? The right side. And tell me what looks abnormal in that side. Yeah, there's some loss of house Shah. What else do you see within them that you don't see on the right side?
Like a friable mucosa.
Yeah, right side looks friable. And then you also see loss of this vasculature. So usually during a normal colonoscopy, you'll be able to see these like little blood vessels, and that you don't see those on the right side. And so you guys correctly identified the abnormal side, which is the right side. And so for our case, today we have a 22-year-old man who's presenting to clinic with pain over his shins. And here's what his shins look like. So I'll let you guys take a look for a second. And the question is, what is this skin finding called? Which in itself is not a diagnosis, but a manifestation or a symptom. Do you guys agree with the answer somebody posted?
Yeah.
Yeah, everyone thinks it's erythema nodosum. Okay, awesome. So that's the correct answer. This is erythema nodosum. And while we're not going to go into erythema nodosum today, it is an extra GI manifestation that's commonly seen in patients with inflammatory bowel diseases. It can also be seen in patients with other rheumatologic conditions like lupus and sarcoidosis. And so look out for that finding. All right, so based on what you know so far about this patient, which is pretty minimal, just that he has erythema nodosum, what questions would you like to ask him?
Probably like a review systems from head to toe.
Yeah, so what specific questions are you gonna ask? Because you're in clinic, you have limited time, you can't do like 100-point ROS.
So it would just basically be like any headaches, vision changes, dizziness, and then nausea, vomiting, diarrhea, bellyache, change of bowel, skin, a little bit weird. Like, this is very non-specific, so, and then I go continue down like any weakness in your limbs, any pain in urination, any blood in your urine.
Okay, tell me what like diagnoses you're thinking of, because again, that was a pretty broad ROS, and so how are we going to decide what we're going to ask this patient about? So the reason I didn't give you a lot of information is because it's important to put the entire patient into context, right? So where I would begin is thinking about, well, what do 22-year-old men get as a disease that may present as erythema nodosum, right? So 22-year-old men generally are healthy and do not have many problems. And so we already talked about how erythema nodosum is seen in patients that have rheumatologic conditions. And so which rheumatologic conditions are most common in 22-year-old men? Yeah, Crohn's, what else? Ulcerative colitis, what else? Yeah, irritable bowel syndrome is not IBD, but yeah, we can think about that. That is a disease that usually is not an autoimmune disease, so wouldn't present with enodosum. But since this is an IBD lecture, it'd be important to think about IBS as well. What else?
Psoriasis.
Psoriasis, yeah, psoriatic arthritis, psoriasis is good. So you would ask about other skin conditions that he may have. Any other ones you guys can think of? So I would also think about RA and lupus, which commonly afflict younger patients as well. And so thinking about all of those and then asking questions more specific to that. So here, he tells you that he noted these bumps 2 weeks ago. He thought they were spider bites, but they didn't go away. And then additionally, you find that in your ROS, for the last month, he's been having fatigue, some dull abdominal pain, arch defecation, he has blood in his stool, but he does not have diarrhea. And then your exam in clinic is this. Is there anything else you guys want on the exam?
Abdominal exam.
Yeah, his abdominal exam had normal bowel sounds. When you push really hard, he had a little bit of tenderness on the left side, but otherwise a normal exam. Any other exam?
I guess maybe just something, I don't know, like joint specific, like is he joint hindering?
Yeah, that's good, Dr. Bacon. Yeah, making sure that you're doing a joint exam that doesn't have evidence of synovitis. That's good. And then just thinking about patients that are complaining of blood in the stool, sometimes a rectal exam can be helpful. So I would encourage you in a patient like this to do a rectal exam. More patients with ulcerative colitis have frank blood on a rectal exam than patients with Crohn's. And so that may point you in one direction versus another. All right, so what is your differential right now based on the ROS and the exam, and what tests would you want to order? Ulcerative colitis, yep. Crohn's, awesome, you guys are doing a great job. Colton already told us one, IBS, right? Internal hemorrhoids, okay, good. You would have hopefully felt those on your exam, but whether you did or didn't, so that's on the differential. What if I told you he did have diarrhea? Now he's having bloody diarrhea. Yeah, so a GI bacterial illness or a viral illness. Yeah, ova and parasites. Yep, good. Here to make sure you do a good social history, travel history for those things. Okay, what test do you guys want? Tell me why. Versus? Yeah, so IBS versus IBD is really what may help you to get fecal calprotectin. If it's elevated, you're more likely to have IBD. Okay. You went with like the most esoteric test first, which is great.
Works.
CBC, awesome. What are you looking for on that?
Anemia and
Yeah, good. Good. C-scope, okay, good, good, yeah. ANA ANCAs, okay, those are, Colton, in the setting of us now knowing that this patient has blood in his stools, some abdominal pain, given his age and his sex, do you think more likely is that he has some kind of irritable bowel, inflammatory bowel disease, or that he has lupus, rheumatoid arthritis type stuff? Yeah, the first one. So for this patient, for now, we would hold off on getting those tests just yet. Yeah, good. And then, so I'll go through this with you. There are a couple other ones we want. So we want a CMP in all of these patients. Most of these you guys got. Make sure that when patients present like this, IBD is somewhat of a diagnosis of exclusion, meaning that you must rule out infections before you can say that a person has IBD. And so you're gonna get C. diff, a stool culture, and ONP and Giardia, all of which were negative in him. And then you also want to get a TSH in these patients, which is normal. And then the fecal calprotectin, the reason I put an asterisk there is the reason that Alex said, which is to differentiate the two. And then if you're suspecting Crohn's, remember that Crohn's patients also need absorption labs, which include all of these, which I did not get for this patient. Cool.
What is your feedback?
Oh, it's
Where's
yeah, it's 24. If on the top right, I have a key for it. Yeah. So I know this one is different.
You do it the way it's for you.
The way I group it like this is the top is hepatocellular pattern, the middle is a cholestatic pattern, the bottom is total protein albumin, which I think are connected, and then INR is just solo. Yeah, so I group them that way so I know what I'm looking at. All right, so here we go. Here's the C scope that you wanted. What do you guys think? Looks normal? No. This is an abnormal colonoscopy. Good, so how much of his colon do you think is affected? Yeah, all if not most of it, right? Because a lot, this doc went through a lot of the colon and all of it looks friable, it looks inflamed. There's no obvious signs of hemorrhage, but he did have some small ulcers. Good. All right. So a very small segue, which is that when you first diagnose somebody with IBD, treatment really depends on the severity with which you start. And so this is the chart for ulcerative colitis, and it includes a lot of things. Number of bowel movements, whether they're having bleeding, what it looks like on endoscopy, and then your global medical assessment, meaning what the patient is complaining of and how severe you think the disease is. Crohn's disease is more difficult to define. And you're gonna base your therapy based on the severity. So the patient representation here is that it's a 22-year-old man presenting with symptoms and labs consistent with IBD, found to have ulcerative colitis based on endoscopic findings. So this is in the outpatient setting. The question is true or false, whether you would treat this patient with steroids to achieve remission. All right, I got one vote for true. Anybody else?
Can you never have remission from UC, or you have to do a total colectomy?
Yeah, great question. So the question was, can you have full remission with UC without doing a colectomy? And the answer is yes, you can have full remission of symptoms and endoscopic findings without having to do a surgery. Okay, so the answer to that is false. Steroids are not first-line therapy to achieve remission in ulcerative colitis. We want to use non-steroidal medications to be able to achieve these. Steroids are often and should be used to help with sort of short-term symptomatic management, and patients can be put on steroid tapers while you up-titrate them on non-steroidal medications, okay? And so I'm not going to present this paper in detail, but there is an article that tells you first-line therapies in IBDs. It's excellent. They basically stratify them with Crohn's and UC. But for ulcerative colitis, there are sort of two trains of thought. For mild to moderate disease, people usually take a step-up approach and they start with this class of medications called 5-ASAs, acetylsalicylates, and these are the medications that you've heard the names of. So mesalamine, sulfasalazine, olasalazine, phylosalazide, all of those are 5-ASAs, and you often see your UC patients on them. Then, if that therapy isn't working, you can add on steroids temporarily to help the 5-ASAs work better for better absorption and for the patient to achieve remission. And then you just keep going up, which ends with surgery. If the patient presents with really severe disease, sometimes it's you just have to go to surgery first, and then you do top-down approach. Okay, so then for our patient, he had mild to moderate disease on presentation. He gets plugged in with GI. He opts for step-up therapy. He's on mesalamine, sort of intermittently requires steroids, and ultimately he ends up on azathioprine, which is also a medication we commonly use to treat ulcerative colitis. The other one that is a immunomodulator is 6-mercaptopurine, which we can also use, so azathioprine or 6-MP. But he returns to the emergency department with bloody diarrhea. This is 6 months later, and he tells you that now he's having more than 10 bloody bowel movements. He has abdominal pain. I gave you guys his vital signs, and he tells you that he moved to Alaska for a bit, didn't have great access to care, but felt he was in remission, and so stopped taking his medications. So what do you think is going on? He's having a UC flare. And now would you categorize his disease as mild, moderate, or severe? Severe. Tell me why you think it's severe.
Greater than 10 bloody bowel movements with a fever.
Yeah, so like the criteria that people fit in and that you can look up on UpToDate are just that. So the number of bowel movements matters, and so it's less than 4 to 10, or more than 10. Fever is a bad sign. Tachycardia is a bad sign. Hemorrhage, so like just having bloody diarrhea is a bad sign, and anemia is a bad sign. And so when you meet one or more of those, multiple of those, you have severe UC flare. So are you gonna send this patient out of the ED, or are you gonna admit them? Yeah, this patient needs to be admitted to the hospital. And so what tests must we do now when a patient presents with an ulcerative colitis flare? And what will be our initial management strategy?
Do C. diff.
Get a C. diff, yep, good. So you have to rule out infection again. And with the C. diff, most people would get a stool culture as well. So we'll get them both. CBC, of course, we want to look for a degree of anemia. Inflammatory markers, yep, because we have a baseline for him, so we're going to see where he is. Yeah, BMP, right? We're going to make that a CMP because we want to look at the liver as well. Induction therapy. Well, I'm not quite sure what they mean by that, whoever wrote that, but we'll keep that in the back of our mind. Okay? I'm thinking they mean induction with a biologic.
I mean, we probably can start up with that. I think I might be worried. Might need like surgical intervention, but I think I'll probably try to cut them off with steroids and potentially getting the biologic.
Yeah, great. So Dr. Brixton says that she thinks that early steroids are indicated, potentially surgical intervention, and then potentially a biologic as well. So all of those are on the table. Okay. Anything else? All right, so you guys are off to a good start. So these are the labs that you asked for. I'll let you take a look for a second. Tell me what jumps out on the basic stuff. Yeah, what do you think those are from? From his diarrhea, yeah. Do you think he has hypervolemic or hypovolemic hyponatremia? Hypovolemic, because he's having diarrhea. Good. What else? Yeah, he's anemic. He's thrombocytopenic, all of which are signs of acute inflammation, right? And his bleeding. Okay. Then these are some of the other labs we asked for. So his ESR and CRP are both much more elevated now. His infection, again, negative. And then remember, you have to type and screen these patients, so order that as soon as you can, so you don't have to keep sticking the patient. And then one test that you guys didn't ask for, but you have to get, is an abdominal film on these patients, because they're at risk for what? Yes. Patients with ulcerative colitis are at risk for toxic megacolon and perforations. And so if you're concerned about that on exam, get a couple views, but this view is sufficient to evaluate for toxic megacolon. Does this patient have it? No. That looks pretty normal, right? Good. All right, so you consulted GI as you need to with all of these patients. They're gonna tell you to order a couple more tests. Which tests do you think they're gonna ask you to order? And more than one answer may be correct. Ooh. People went for it. Anybody else? Okay. Hepatitis, why?
And because probably thinking about starting immunologic therapy, so you want to have B.
Yeah. Awesome, Dr. Lackitz. Yeah. Okay, so good. So let's go through these. So the correct answer for this question, which was a bit of a read my mind and read GI's mind, is a HEP panel and a quant gold. And what we're looking for on the HEP panel is specifically hepatitis B, and the quant gold and the hep B are for the same reason, which is that because we think biologic therapy in this patient is highly likely, and most commonly is with the anti-TNF agent. When you give somebody anti-TNF agent, high risk of their latent TB or their hep B reactivating. And so if you're even thinking that this patient may get a biologic in the future, please go ahead and get these tests early, because the quant takes a while to come back, and we want to try to get them on biologic sooner rather than later if we're able to during the hospitalization. The HIV and the blood cultures are not unreasonable. The patient was tacky, had a fever, so perhaps blood cultures, but it's more likely that those symptoms are due to his severe ulcerative colitis flare. And then HIV, if he hasn't had one in the past, is reasonable, but if he doesn't have any new risk factors and already has had a negative in the past, we don't necessarily need to get it. Yeah, so is that why the FOBT, is that what you're mentioning? Okay. Yeah, the FOBT you do not need, nor should you ever get, because he's having bloody bowel movements.
No, I just meant.
Okay, there's a chat question, which I'll tell you guys. When you rule out infection, a C. diff, stool culture, OP, and PCR negative, inflammatory markers high regardless of infection versus IBD flare, correct? Oh, Dr. Herder, really the stool cultures, you're gonna go ahead and start steroids, which is the therapy of choice in patients with ulcerative colitis flares, because that's your most likely diagnosis in this case. I think the stool ONP, if it turns up positive, you can employ antibiotics. There's also thought that in these patients, if they have a peritoneal exam on admission, or if their KUB suggests that they may have toxic megacolon, may have a small perforation. If you're concerned for things like an abscess, you should start antibiotics early. And that typically includes a combination of a fluoroquinolone, so ciprofloxacin, and metronidazole. And that therapy should be able to treat your most common GI bugs, which would include the ones that turn up positive on the culture. Do you guys have any other questions about this? Okay. So a couple other things for initial management is doing our good medicine, right? We're all medical doctors, and the first thing you're gonna think about is how am I gonna manage his fever, his tachycardia, and making sure that you're giving these patients IV fluids, you're replacing their electrolytes. get some amount of CBCs if he's still having a lot of bloody diarrhea. So as far as initial med management goes, for ulcerative colitis and really Crohn's flares, steroids are the choice of medicine. And so you're going to start high dose IV steroids. So this person started on IV methylpred 20Q8. You need to perform serial abdominal exams, again, for the concern of toxic megacolon, and then make sure you're consulting GI. All right, so a couple questions coming up your way. So would you advocate for a fleg sig like immediately upon admission? No, people are saying no. Why not? Yeah, good. So with such an active flare, there's a high risk of perforation with fleg sig. Colonoscopy is a very high risk procedure, which is why we want to do just a flexible sigmoidoscopy, which is a much shorter scope. And typically GI will wait a few days into the steroids to see if they're having any improvement. And if there is some improvement and it seems like the patient has stabilized, they're not bleeding as much, then they'll go in and do a fleg sig. And we'll talk about why we need to do that. All right, another question. If the patient is very bothered by diarrhea, I'm going to prescribe loperamide. Yeah, no, good. So the correct answer again is no. You want to avoid antimotility agents in these patients. The risk of ileus and then toxic megacolon again is high. So please do not give these patients any antimotility agents. That includes like other meds that have anticholinergic effects. So be mindful of using a scopolamine patch for his nausea. Use something else that has less anticholinergic effect. All right, one last question. I would prescribe prophylactic anticoagulation for this patient. Dr. Brixton says no. I'm seeing some yeses. Not sure. Does anybody have a firm answer?
Yes.
Yes. Why yes?
Because the bleeding is not it's from the inflammation, not from like so that's going to keep bleeding. With you're not worried about worsening the bleed with the anticoagulation. That's what I'm trying to say.
Yeah. So actually, you are a little worried about increasing the bleeding with the anticoagulation, but we have very robust data that says patients with IBD, Crohn's, and UC are at like multifold higher risk for VTE than a normal population. And it's like a very high risk. So even when patients come in bleeding, as much as this patient is bleeding, you're still going to consider anticoagulating him. You may get more frequent CBCs to see what the trend is. If it's still downtrending and you're becoming concerned, you can hold off. But really the suggestion is that unless the patient is hemodynamically unstable from their bleed, only then you should use mechanical prophylaxis with SCDs. In all other cases, you should use prophylactic anticoagulation, okay? So for IBD, you gotta prophylactic anticoagulate, even if they're bleeding. All right, so what happens with this patient? So we're gonna anticoagulate him. So you're starting him on Lovenox. You're making sure that his hemodynamics stay okay. You're checking his anemia. You're gonna avoid these antimotility agents. We wanna get the fleg sig because you wanna, A, not only look at disease severity by looking directly at the mucosa, but B, most of these patients need biopsies to evaluate for CMV infection, which is really common in ulcerative colitis. And then again, like we talked about, most patients likely need to go on a biologic at this point, which is why we need the TB and the Hep B. Remember that once a patient starts on a biologic, they cannot get any live vaccines. And so if they need to get MMR or whatever else that's live, that needs to happen 4 weeks prior to a biologic. Fortunately now our shingles vaccine is no longer live. The Shingrix is inactive, so that one the patient can get anytime. Okay, and then a little sort of work chart for you guys. So when a patient is admitted with a severe ulcerative colitis flare, as Dr. Brixton earlier mentioned, there is lots of options to treat this patient. If they have toxic megacolon or perforation, you're gonna automatically go to surgery, which is a colectomy. If they don't, then you can start the patient on high-dose steroids. If on the steroids you're starting to see improvements on day 3, 4, 5, and improvement really is based on decreased frequency of diarrhea and ideally stabilization in their anemia. If that's the case, then you can start them on a biologic, which is usually infliximab, which has the best data in both ulcerative colitis and Crohn's. If you're not seeing much improvement with the steroids and the patient continues to have a lot of bloody diarrhea, that's when you need to consider surgery for this patient inpatient. Using things like mesalamine, some of our other immunomodulators in this case tends not to help. And so this is the flow chart that really GI is thinking about. Often GI early on for these severe flares will ask you to consult colorectal surgery. So that's something that you should think about and think about when to get them involved. And then the only last thing I want to mention is some of you may have picked this up on his second set of labs, but his ALK-Phos is much more higher than it was on admission. And this doesn't happen this quickly, but what you need to make sure you're focusing on is the ALK-Phos, because ulcerative colitis, more so than Crohn's, is closely associated with primary sclerosing cholangitis. And so the way this diagram works is if you have ulcerative colitis, there's a 3 to 5% chance that you are going to have PSC. If you have PSC, there's a 70% chance that you have ulcerative colitis. So they're linked with each other. And so if you have ulcerative colitis, usually the way PSC presents is asymptomatically, and the first sign is an elevated ALK-Phos. And so ulcerative colitis patients should routinely get their hepatic function panel checked to make sure you're looking for PSC. If the ALK-Phos is elevated, your first step is going to be an abdominal ultrasound to look for biliary duct abnormalities. If that's negative and you're still concerned, then MRCP is the test of choice. Okay, and then the diagram that everyone wants to see, and I try to make it as high yield for you guys as possible, and you can look through this. The biggest thing I want to emphasize is on exams, when they give you biopsy findings, they actually are very similar, which is something I didn't realize. Both UC and Crohn's can cause crypt distortion, but only Crohn's has granuloma. So if you see the word granuloma, it's Crohn's. Otherwise, the biopsy is not very helpful. And then sort of where it's located is super helpful because UC has to be in the rectum. The rectum is always involved, and then it progresses proximally. And as you guys know, Crohn's is skip lesions. It can happen in the upper and the lower GI tracts. And then the medications differ a little bit. The acetylsalicylates don't work super well in Crohn's, and so we don't use them in that disease process. For patients that just have right-sided disease, so just proctocolitis or proctitis, for those patients, you can use topical ASAs or topical steroids. Those are all in the forms of like suppositories and foam enemas, which lots of patients don't want to use regularly. So often they'll end up on oral therapy anyway. And then just going through some health disparities with IBD. So historically, IBD is thought of as a disease of the affluent, like white population. And given this, there's underdiagnosis in people that aren't of that population. But there's more and more data that is coming out that suggests that the incidence is increasing both inside and outside of the US. And I just wondered whether this was a result of globalization of the diet, because the diet of the world is becoming more similar to the Western diet. Some other things. So while most studies, and there are quite a few, suggest that there's no difference in disease severity between races, that infliximab and surgical interventions are both seen in lower numbers of Black patients and Hispanic patients than white patients. And then not only related to race, but socioeconomic status is if you have Medicaid versus private insurance, your in-hospital mortality is likely to be 3.3 times higher. So the odds ratio is quite large if you have Medicaid. So just thinking about how we're taking care of each of this population of patients. The last thing I want to talk about is making sure that you screen these patients for mood disorders. Often patients that have IBD are diagnosed at a very young age. And so imagine yourself having an ostomy when you're 20s, it's pretty traumatic. And you may be less likely to do all the things that you enjoy. There has been much more positive representation of ostomies in the media. Aerie did a campaign where one of their models had an ostomy. And there are a lot more support groups for ostomies, people talking about how to exercise with an ostomy. There's lots of resources on the web for patients in this cohort. So just to wrap up, we talked about the 2 diseases, mostly ulcerative colitis today, using steroids for flares in the inpatient setting as your first line management, and then linking UC with PSC. Just to go back to this question earlier, I gave you guys lots of derm findings here. And our self-directed learning for today is going to be matching these diseases to those diagnoses. And so we can do that now. What is the first picture? So none of these are erythema nodosum. That was our first patient. So this patient is thigh, which is where there's a lot of fatty tissue. Yeah, it's lupus paniculitis. It just looks like indentation in the fat. I looked at a lot of these pictures and they all look the same. It's sort of like this indentation, some discoloration in fatty areas. What's the second one? Yeah, this is pyoderma gangrenosum. Often misdiagnosed as an infection, and people will treat this with antibiotics and it will continue to get worse. This needs to be treated with steroids. This will get worse if you try to debride it as well. So test questions often will be that somebody presents with this finding. They go multiple INDs, but the area is expanding because you're treating pyoderma gangrenosum the wrong way. So no antibiotics, no surgery, use steroids. What's the third one? So that's arachnidism, fancy word for spider bites, which can often become necrotic, but they're usually more localized.
Cancel code white, cancel code white, cancel code white. All teams, please return your sheet back to the police service window. All teams, please return your sheets back to the police service window. All teams, please return your sheets back to the police service window.
Okay, and then this last one is acute urticaria, or I shouldn't say acute, I don't know the chronicity of this patient's urticaria, but these are what coalescing hives look like. Sometimes erythema nodosum can be confused for hives, but hives do tend to have more itching and less tenderness than erythema nodosum. And they would tend to be more diffusely on the body, where nodosum typically is on the extensor surface of your lower extremities. And then we talked about this a little bit briefly, but the differential for nodosum is even more broader than what we talked about. So I encourage you guys to look into it and to think about what questions you're going to ask the next patient you see that has it. Cool. That's all I had. Do you have any questions or comments? Okay, cool.